All right. Well, thank you for sticking with us, members. I know it gets to be a pretty long meeting as we are approaching deadlines here, and we have a lot of work to do, but we are moving along really well. So I'm hoping that we'll be perhaps ending a little bit earlier than our stated time this evening. So the next bill on the agenda is House File 2016, Representative Reyer. And Representative Reyer's motion is that House File 2016 be laid over for possible inclusion in the finance bill. Representative Reyer.
Thank you, Chair Liebling and members. I'm pleased to have the opportunity to present House File 2016. It's a Department of Health policy bill that modifies requirements for annual reporting on spending related to chronic conditions and risk behaviors. More specifically, MDH has 4 requirements. First, to identify healthcare spending directly attributable to diabetes, hypertension, dementia, obesity, and smoking, and all chronic disease costs for those 60 and over. So first identify. Second, project future levels of condition attributable spending, and then compare that spending to the conditions and risk factors with a projection baseline. Finally, taking the share of the difference between those actual and projected spending amounts that can be attributed to state-administered programs. Basically an impact measurement. MDH is required to conduct the analysis annually, certify it, and deliver the findings to Minnesota Management and Budget so the commissioner may initiate transfer of funds between the general fund and the Healthcare Access Fund if the conditions in the statute are met performance-wise. Now, this bill proposes 2 changes, moving from annual to biannual reporting and removing costs related to the utilization of tobacco products. Both of these changes are grounded in ensuring that the data used to drive financial actions are up to the task. We need our reporting to be valid and reliable, which requires matching of the data and the reporting period to the need. In terms of data quality, this is a challenging task as researchers are working with claims data and linking and triangulating census and other survey and behavioral data. Each additional layer of data has its own assumption and brings its own noise. MDH makes a substantial investment in this work. The sophistication of these analysis requires a strong outside partner. So MDH works with Mathematica Policy Research, and the most recent cost was almost $300,000 for 2016 data analysis. Moreover, the MDH staff put in substantial times to supervise and provide technical assistance to the vendor and to interpret and communicate the results and implications. Regarding the reporting time period, this reporting seeks to measure changes from spending on chronic conditions that may not be quickly observable. Thus, seeing an annual impact may not be realistic, and over-reliance on annual reporting may be risky. This is particularly challenging with tobacco data because tobacco exposure is poorly captured in claims data. Some of the tobacco-related survey data are collected only every other year. There's a long lag between starting to use tobacco and adverse health outcomes. And finally, costs associated with secondhand smoking exposure are difficult to determine. For these reasons, I support this bill and also ask for your support. In addition to improving the quality of the reports, I'd like to see the reporting team's time and budget freed up for other important analyses. With that, I will look forward to your questions, and I believe Stefan Gildemeister is also here to help with detailed or technical questions. Thank you.
All right. Thank you very much, Representative Reyer. Are there any questions on House File 2016? All right, I'm not seeing any. That was a really good explanation of what the bill is doing, Representative Reyer. Thank you very much for that. Okay, not seeing anything. So very good. You might get the prize for the shortest. Oh, there we go, Representative Pryor. Darn, almost got the
I was just going to say, we're here, we were listening. You weren't talking to an empty Zoom room.
I would expect nothing less.
All right. Well, thank you. Thank you again, Representative Reyer. And with that, House File 2016 is laid over for possible inclusion in the Finance Bill. Very good. Next up is Representative Boldon, House File 2055. And House File 2055, Representative Boldon's motion that it be laid over for possible inclusion in the Finance Bill. Representative Boldon.
Thank you, Madam Chair. House File 2055 is a straightforward Minnesota Department of Health policy bill aiming to add inclusivity and conformity to the International Medical Graduate Assistance Program language to include general surgery. In 2015, Minnesota legislatively created the International Medical Graduate Assistance Program to address barriers to practice and facilitate pathways to assist immigrant international medical graduates to integrate into Minnesota's healthcare delivery system. The program authorizes the Commissioner of Health to award grants to support primary care residency positions designated for Minnesota immigrant physicians who are willing to serve in rural or underserved areas of the state. Per the legislation, eligible primary care residency grant recipients include the following accredited residency programs: family medicine, internal medicine, obstetrics and gynecology, and psychiatry. This bill would add general surgery residency programs to that list. MDH was approached by staff at the University of Minnesota through the Office of the Dean Graduate Medical Education about feedback they received from general surgery residency program directors asking why they were excluded from the definition of primary care in the above mentioned legislation. There was no specific reason as to why they were excluded. Other grant programs do include general surgery in the definition of primary care. It would be beneficial to expand the definition of primary care in the Internal Medical Graduate Assistance Program to include general surgery for a few reasons. One, it aligns this program with other grant programs. Two, it allows international medical graduates who have experience and interest in general surgery to continue in their area of practice, an area of practice that is needed in rural areas. And three, it also allows us to be responsive and to reasonable suggestions from the program. And with that, Madam Chair, I'll pause for any questions and note that we also have a representative from MDH to assist with any technical questions as needed.
All right. Well, thank you very much, Representative Boldon. Are there questions from members? Okay, I don't see any. I have just a small question, Representative Boldon. So your explanation was really great. And so normally I don't think of surgery as being part of primary care, but my understanding is that you're adding it to the definition, but only for purposes of this program. Am I correct there?
That is correct. So I actually had that thought initially too, but so you're correct. And I also would add that, the other residency programs, so there's family medicine, internal medicine, obstetrics and gynecology, and psychiatry. So it fits in line with sort of the package of those other residency programs. And this would be in line with other similar programs.
All right, thank you. Questions? Representative Bierman.
Thank you, Madam Chair. I just had a question for Rep. Boldon. Do you know the level of applicants that are applying for these grants and what the relative number is comparatively to the grants that are available? Representative
Boldon.
Thank you for that question, Representative Bierman. I do not have that information, but I know we do have, as I said, someone from DHS, MDH on the call who maybe would have that information.
Okay, is there someone on the call that can respond to that?
Hi, Madam Chair, members of the committee. For the record, I'm Lisa Timian, and I'm Legislative Director at MDH. And I believe my colleague Yende Anderson is on and speak to the actual number because I do not have that handy. And if she doesn't, we can get back to the committee with that information later today.
All right, thank you.
Hi, Lisa, Chairwoman, Representative Liebling. I do have a number available for you. Every year we have had at least 2 applicants for the residency program. This program encompasses other grants, but for the residency grant, we've had at least 2 one from the University of Minnesota and 1 or 2 from Hennepin Health.
All right, thank you. And could you just say your name and who you work for, just for the record?
I'm sorry. My name is Yende Anderson, and I work for Minnesota Department of Health.
All right, thank you. Representative Bierman?
Thank you, Madam Chair. No other questions, just to comment. I think I like the grant program, the idea of helping out to get the doctors where we need them throughout the state. So thanks to Rep. Boldon for bringing it forward.
All right, thank you, Representative Bierman. Any other questions or comments from members? Okay, not seeing any. So with that, we will lay over House File 2055 for possible inclusion in the finance bill. Thank you, Representative Boldon. Moving right along, next, Representative Jordan. I see that she is here and she brings us House File 2048, and the chair will move that House File 2048 be laid over for possible inclusion in the finance bill. Welcome, Representative Jordan. Please go ahead.
Well, thank you, Madam Chair, and good evening, members of the committee. I'm honored to discuss House File 2048, an agency bill I've been working on with MDH, which would allow Minnesota to use the most recent and best possible science to protect all of us from exposure to carcinogens through our groundwater. MDH sets health risk limits for groundwater, determining health protective limits for concentrations of chemicals and possible carcinogens in our groundwater supply. And currently, MDH must rely upon data from the federal EPA. So as a result, MDH depends on data that's not always the most up-to-date or accurate because the EPA tends to be a little bit more slow-moving. So this bill would enable MDH to use other data and studies that have undergone scientific review and have been approved by the commissioner. So often information received from other sources, such as universities and state agencies, is quicker to follow the most recent research and science. This bill does not preclude MDH from using data from the EPA, but enables the commissioner to use the best possible information to protect Minnesotans' health and well-being. So in short, House File 2048 is more protective of Minnesotans and our groundwater. And with that, I, along with folks from MDH, are here to answer questions any members of the committee may have.
All right, well, thank you, Representative Jordan. We appreciate that. And we'll give members a minute or two if you have questions on House File 2048. And members will recall that it's a little bit not always intuitive for us that groundwater protection is, in fact, in Department of Health. I mean, it does make a lot of sense, but we don't think about it that way often. All right, I'm not seeing any questions. So I don't want to rush you if you have them because we do have plenty of time. All right, Representative Grunhagen.
I hate to fail you, Chairman Liebling. Say, I understand the impetus behind this, Representative Jordan, and I know your concern, but I do think that the EPA is national, and I do have, it does cause me pause to put this much additional responsibility to MDH without a check and balance. And, we already have agencies doing rulemaking, and I guess I'd like to leave it as it is. I need more information, but I'm just not ready at this point to turn that over to the MDH. So, okay, thank you. She can respond if she wants, but I just wanted to express my concern. Thank you.
All right, thank you, Representative Grunhagen. Do you want to respond to that, Representative Jordan? Because it seems like there's a little misunderstanding about what the bill actually does.
Sure. Yeah, I'd love to. Thank you, Madam Chair, and thank you, Representative Grunhagen, for the question. I really do welcome the opportunity to talk about this. So this allows the commissioner to continue to use the EPA, and it actually says that they should use the EPA. The EPA is still cited in the statute. This just also allows MDH to use other data to protect Minnesotans from carcinogens in drinking water. I know that if there is research from the University of Minnesota, for example, or a study done by MDH that says that there are carcinogens in groundwater that my constituents drink water from the Mississippi, but if there is groundwater, which is a source of drinking water for many Minnesotans that has carcinogens in it, I want us to have the most up-to-date and accurate information to be able to use for MDH to use to make these decisions. So I think it's just really important that this gives MDH more tools in their toolbox to protect our drinking water.
All right,
Yeah.
Representative Gruenhagen.
Yeah, well, thank you. Thank you for that response, Representative Jordan. You know, I did serve on the subcommittee of water, clean water, for a couple of years. And one of the things that came out there is that some of the MPCA and agencies were using non-peer-reviewed science to set requirements, and even a couple of the DFL representatives had concerns about that. It just gives me pause. I just think if there's additional data that MDH has, they could ask for a waiver or submit it to the EPA. And I don't see why they wouldn't give them a waiver or show some concern. But I guess at this point, I really can't support this. I have agencies in general need some checks and balances, and this tends to go the opposite direction that I would be comfortable with. Anyway, those are just my comments. Thank you.
All right. Thank you, Representative Gruenhagen. Next, Representative Bierman.
Thank you, Madam Chair. Thank you, Representative Jordan, for bringing the bill forward. It seems to me that the more people we have checking on our water supply and how good it is a good thing and an important thing. And I'm just wondering about the intersect between the Minnesota Pollution Control Agency and the Minnesota Department of Health. What are the lines between them, if any? And also, do you know how frequently the water quality is checked for those sources of water for Minneapolis area? Is it yearly or monthly, or when was the last time the water source was really looked at in terms of how healthy it is for drinking? I know Minneapolis gets a lot of water from just the north part of the metro Mississippi area is what I understood. And they don't do as many checks on that as I thought. So just a lot of questions there, but just wanted to get a sense of that.
Representative Jordan.
Thank you, Madam Chair. I think those would be really great questions for MDH to answer.
Yeah, who do we have here from MDH that can take those questions?
I can certainly do that, Madam Chair.
All right, Mr. Kelly, please introduce yourself.
My name is Jim Kelly, and for the record, I work for the Minnesota Department of Health, and I'm the manager of the Environmental Surveillance and Assessment section. So a couple of things there with regards to the monitoring of the source waters, say for the city of Minneapolis, which is the Mississippi River. We have a significant project at this point that's going on from our drinking water protection program that's looking at the quality of source waters around the state, especially surface waters, where we're sampling for a wide range of contaminants just to see what potentially is upstream of the city of Minneapolis and St. Paul's, for that matter, water intakes. Data will be coming out of that effort later this year. And it is something that the city, of course, has to monitor on a frequent basis what's coming into the plant so that they can take action quickly to turn off the intakes if there is some sort of a spill or something going on upriver. So I think we have a pretty robust system for looking for those contaminants and responding in a timely manner if it becomes necessary.
All right, thank you, Mr. Kelly. Representative Bierman, anything further?
No, that's good. Thank you, Madam Chair.
Okay. All right, thank you. Representative Morrison and then Munson.
Thank you, Madam Chair. And I just wanted to thank Representative Jordan for bringing this bill forward. Our water is our most precious resource in Minnesota in many ways, and it is under threat from all kinds of different directions. And if anything, I would say that the pendulum has swung toward not many checks and balances on industry. So I appreciate having more eyes on water than fewer. And I applaud the Department of Health's work on it already and their future involvement if need be, as the bill enumerates, if monitoring shows that there is degradation. So thank you, Representative Jordan.
All right, thank you. And Representative Munson.
Yeah, thank you, Madam Chair. I know we heard a bill, I think we heard a bill similar to this before. My concerns are really around the intersection between the Minnesota Department of Health and the in the Department of Ag. This bill really, I think, would impact agricultural practices upstream from the cities. And my concerns are around kind of getting involved with what chemicals farmers use and kind of overlapping what the Department of Ag does. Is this bill going to the Ag Committee as well? Or where does the, Minnesota Department of Ag have authority to regulate chemicals that are used in farming practices versus where the Department of Health now would be involved? I guess we'd ask maybe the Department of Health. So
Mr. Kelly might be the best one to answer that. Let me take a stab at it though, Mr. Kelly. Tell me if I'm wrong. I would guess that the Department of Ag's business ends where our drinking water starts. But you please, you answer.
Thank you, Madam Chair and Representative. That's basically correct. Our role in the Groundwater Protection Act of the Department of Health is to simply establish the thresholds that define the level of a contaminant in groundwater that's safe for human consumption for up to a lifetime. That's really the extent of it. When it comes to the application of those values out in the environment, so to speak, that is the purview of both the Department of Agriculture when it comes to pesticides and fertilizer use, as well as the Pollution Control Agency when it comes to chemical spills and releases. So they simply look to us for the barometer, the benchmark to define what's an acceptable level of contamination in groundwater. Then they have other provisions of the Groundwater Protection Act that they apply as necessary to impact the use of chemicals on the land that could then contribute to groundwater contamination. So our role is fairly limited in simply setting that benchmark and consulting with them if they have questions about how that maybe should be applied when it comes to their programmatic areas.
Representative Munson, anything further?
Yeah, I mean, I just think that, we all want clean water, but we also want food. And so we need to balance those two priorities. So yeah, thank you.
Well, Representative Munson, we might differ about how we balance those priorities. I think that if our water is poisoning us, then I think we got some problems. Representative Backer?
Yeah, I have a question here. And this probably goes to the author, but in regards with this bill here, do we trust MDH with the power to, single-handedly set health risk limits? It seems like we're putting a lot of emphasis in one department.
Representative Jordan, do you want to take that?
Yes, Madam Chair. We already do. That's the bill right now just would change the difference in what data the commissioner will use. So right now the law says that they must use data from the federal EPA or the EPA and other sources. This law, the only thing this law changes is that it says is the word or. It's the word and from or. So that's already the law, Representative Baker.
Okay,
and I don't know if the MDH has other experts to say more about that.
Representative Backer, follow up.
Yeah, Representative Jordan, that still concerns me, even though it's the law doesn't mean it's correct. I know what you're trying to get to. My concern is this would even, and means you have to get two things to happen, or means one or the other. I get that, but I still have concerns that MDH would have single-handedly, we're making an assumption that they have the right data. Now, I get it that you want to have EPA also weigh into it too, but it seems to me even giving more power two agencies, and like that's what it concerns me. Because if we would more stringent limits, even though the data may not be accurate, does put limitations on there. I think at the end of the day, we all want to make sure that we're getting safe resources, but that just would be my concern. I want to share that for the record. I do appreciate it. Thank you.
All right. Thank you. Representative Bierman.
Thank you, Madam Chair, for a second question. I just wanted to ask Mr. Kelly, please, for the relative size of the Minnesota Department of Health, the number of people who are looking at the water issues versus how many people are looking at it from the EPA side.
Mr. Kelly.
Madam Chair, Representative, that's a hard question for me to answer specifically because I'm not as well versed in what the EPA's resources are. We have a unit of scientists that conduct this work on behalf of the department of about 8 people. EPA certainly has many different staff scattered across institutions around the country. But as I think the author pointed out, they're sometimes not as quick as they could be when it comes to updating the science around specific chemicals, especially chemicals that could be of concern to the state of Minnesota. So I can't comment specifically as to how many resources the EPA has. I can only speak to what I have in my own agency.
Thank you, Madam Chair. Thank you, Mr. Kelly. And so that's kind of the point of my question. I'm just wondering, if we don't know what the EPA is looking at and how intentional their work is on our water, it would behoove us to make sure with our own staff on something as critical as water that we're on top of it. So thank you very much.
All right. Thank you, Representative Bierman. I'm going to take the last question from Representative Quam.
Thank you, Madam Chair. And to the author, the simple replacing an and with an or raises some concern with me. The EPA is involved in a lot of international activity. It's an outfit that has a lot of information. I know that we may be cooperative with the Great Lakes on some international work on water quality, but an and means that we need to review and look at what the federal government, which has a much broader staffing and exposure to information, where an or allows the possibility that we just sort of stop listening to what they have and maybe don't hear things that we ought to. So my concern is I like and because you have a broader view, and I have concerns about what do you lose when you stop looking at the federal. So would the author be able to tell me what things that we have as a state that absolutely fully encompass everything that the EPA would have so that we don't lose anything when we drop them out with the and just allow the or?
Representative Jordan.
Thank you, Madam Chair. And thank you, Representative Plum, for the question. I don't think we lose anything. We're not getting rid of the EPA. We're expanding the tools for MDH to assess carcinogens in our groundwater supply. If there's carcinogens that are affecting the water that my constituents drink, I want MDH to be able to use the data and to find that out to protect my constituents. We're not losing anything. We're expanding the scope of what MDH can use to protect Minnesotans. So that's why I really like this rule change, and that's why I'm really happy to work with them on this bill.
All right. Well, thank you so much, Representative Jordan. And thank you, members, for the questions. And before I lay this bill over, I would just say that I like the idea that the people who are testing the groundwater are also drinking it. These people live in Minnesota. So I think it's comforting to me. They're protecting their own homes and families as well. So with that, thank you, Representative Jordan. House File 2048 is laid over for possible inclusion in the finance bill. Our final bill for the evening, and we are nicely ahead of schedule, is House File 447, Representative Acomb. So she is not on the committee, so the chair will move that House File 447 be re-referred to State Government Finance and Elections Committee. So this is one that we'll be voting out. And Representative Acomb, welcome.
Good afternoon, Madam Chair and members of the Health, Finance, and Policy Committee. Thank you for the opportunity to present House File 447, a bill to improve breast cancer screening. Dana Carter with the Susan G. Komen organization has submitted some written testimony in lieu of an appearance today. As many of you know, breast cancer is one of the most common forms of cancer affecting women. In fact, 1 in 8 of all women will be diagnosed with breast cancer at some point in their lifetime. In Minnesota alone, 4,850 women will be diagnosed with breast cancer, and 640 will die from the disease this year alone. Breast cancer is the second leading cause of cancer death in women. To combat this, the medical community agrees on the benefit and value of early diagnosis. According to the American Cancer Society, women with breast cancer identified and treated early have a 5-year survival rate of 99%, compared to a projected 28% survival rate for those diagnosed late. As a result, regular mammograms are among the basic preventative services recommended by the federal government and are covered by most insurance plans nationwide at no cost to the patient. When a woman's regular screening, a mammogram, indicates something unusual, her doctor often orders a follow-up diagnostic scan to clarify the issue. To most women, any follow-up test is still part of the overall preventative screening process. However, follow-up diagnostic testing is not always free and can be subject to a wide variety of cost-sharing terms established by individual health plans. This can create an unintended financial barrier for women to this important health screening process. I have personally seen this problem myself. In the past, my doctor brought me back for follow-up testing after a routine mammogram showed an area of concern. When arranging the second appointment, I remember the scheduler telling me that I would need to pay $150 for the follow-up procedure, even though the first mammogram was free. I questioned this since my doctor ordered the second test to fully evaluate my initial screening. She said it was due to my health insurance, but that I was worth it, and whatever the cost was. I did think I was worth it, and I believe all women are worth it. For the same reason that preventative mammograms are free, this bill seeks to ensure that no woman postpones or forgoes completing their breast cancer screening due to financial barriers. Some might argue that this is an added health insurance mandate that will increase costs, but I disagree. When the federal government established preventative guidelines for mammograms, they did so on strong scientific evidence that doing so would reduce deaths, increase survival rates, lengthen life expectancy, and save money. In fact, the CDC cites multiple studies on their website that show breast cancers diagnosed in early stages are much less expensive to treat than those diagnosed at a late stage. Free preventative breast cancer screenings are already a basic requirement for health plans precisely because they are effective and save money. Any additional tests needed to clarify the findings of those regular mammograms should be part of that same free process. I am a breast cancer survivor myself, and I believe my success is due to early diagnosis and treatment. I also believe that all women should have barrier-free access to early diagnosis and the same chance to overcome cancer that I was given. I would ask for your support of House File 447, and I stand for questions.
All right. Well, thank you very much, Representative Acomb. So are there questions from members? Representative Demuth.
Thank you, Madam Chair, and thank you, Representative Acomb, for bringing this forward. I too am a breast cancer survivor. And if we were in the same room, I would high five you at the end of our hearing. So we'll virtual do that. But I do have a couple of questions. I do have a couple of questions on the bill. We know that this is important, that early diagnosis. I fully agree with that. As you related that story of when your doctor calls you back for the next test, you know, everything that goes with that. And I agree that finances shouldn't be a barrier, but knowing how important it is, I see in the bill, and I believe it's line 112, that we are exempting, it doesn't apply to medical assistants or Minnesota Care. Do you know what our Minnesota Care people may be having to pay for secondary testing? And if you or want to relate that to someone else, if you could just answer that question. I do believe that it is important.
Representative Acomb.
Thank you, Madam Chair and Representative Demuth, and congratulations on your beating breast cancer. So truly, I think it should go to all programs, you know, public and private insurance. And really it was budgetary that I opted to do this given the budget situation in the state as we started out the session. It's a little different scenario today. But I did reach out to Doug Berg, and I know there's a fiscal note that's being put together, and I did ask him to see if he could help me find out what the cost would be to those people with Minnesota Care and medical assistance. And so I did check with him before committee started today, and he had not heard back anything. So I don't have that information, but I'm looking for it, and I will certainly pass it on when I do have that.
All right, Representative Demuth, anything further?
Thank you, Madam Chair. And just as a follow-up then, I would be interested when you gave the stat of 1 in 8, and we know that well, but I would be interested in the number that actually affects. Thankfully, there's 7 in 8 that don't get that call back, and so maybe our number is a little bit smaller than we're thinking, but thank you very much for bringing this forward. Thank you, Madam Chair.
Thank you, Representative Demuth. And I wonder if there's anybody from DHS who can answer the question, because my understanding is that on our MA program, of course, the out-of-pockets are very low. So I don't know. I doubt very much there's a $150 charge for a second follow-up that's necessary. And in addition, even in our Minnesota Care program, our out-of-pockets, while they're a bit higher, are also very low. Giogo, welcome. Could introduce yourself.
Thank you, Madam Chair. Member Giogo Hayes with the Minnesota Department of Human Services. So to answer the question, we do have, I believe it's a $3 copay for non-preventative visits in the Medicaid program. That's stipulated in state law. And then in Minnesota Care, we also have a copay. I don't remember exactly what it is off the top of my head, and I apologize, but the program itself hits a 94% actuarial value. So recipients are only paying 6% of the aggregate care that they're receiving in the Minnesota Care program. So it certainly is unlikely to hit that $150 mark that was mentioned earlier. But if there was interest in making the change, there would be a slight cost, likely a slight cost to the Medicaid and Minnesota Care programs as the follow-up visit to the follow-up diagnostic tests are potentially eligible today.
All right. Well, thank you very much, Mr. Hayes. And, you know, obviously, I would just want to be sure to note that for the people who's, you know, people are on these programs because their incomes are lower. So, of course, a $3 charge for someone on MA can be quite a bit, as could, you know, on the Minnesota Care program, because these are, by definition, low-income folks. So thank you. Okay, Representative Ackland and then Quam. Representative Ackland. And you are muted.
Thank you. Thank you, Madam Chair. My question's for Representative Acomb. And I don't want this question to be understood as a suggestion, and I don't want it to be understood as a criticism either. But I just felt like we need to maybe talk through this a little bit. So you've chosen the mammograms for additional testing, or additional testing related to mammograms, instead of possibly another diagnostic test. So you mentioned some of the statistics around breast cancer, but I know that heart disease is the #1 killer of women in the United States. And I am a personal survivor of heart disease. I know that the #2 killer of women in the United States is cancer, but it's not breast cancer. The #2 killer is lung cancer, and breast cancer is #3. So my question comes to you, and like I said, not in the way of a criticism, but just as we're going down this path, it makes me wonder, why would we choose one diagnostic test to the exclusion of other diagnostic tests and move down that path? So for instance, if you have a mammogram, you need additional testing. You might get first an ultrasound, then you might get an MRI, then you might get a possible biopsy. Then that biopsy would require a pathology test. And so the path can go pretty far. But the same way happens with heart disease. You go to the doctor with a twinge in your chest, you get an EKG, maybe you need a treadmill, maybe you need an angiogram, oh, maybe you need a stent, maybe you need open heart surgery. Well, all those tests leading up to it. So I just am coming to you with the question. I understand breast cancer is very well known, so is heart disease. And so as far as this bill is concerned, I just wondering, and I don't even know exactly how to ask the question. It's just that to pick this one and say, you can get this test and no further diagnostic test doesn't seem to me to fit into our bigger picture that #1, heart disease is actually #1 killer of women. So why would we not pick that disease, or why would we not pick lung cancer since it's the #2? So that's my question. Thank you.
Representative Acomb.
Thank you, Madam Chair and Representative Ackland. I picked this bill and this cause because I experienced it. And so I think, we have this representative government where we all come here with our perspective and with our experience. And it's hopeful that then that represents our community. And I haven't experienced heart disease, and so I'm not as familiar with that. I went through the experience of being diagnosed with breast cancer, and I think that for those of us that are women, we've had, many of us anyway, have had mammograms at least, once or annually or however often you get them. And when we go through a process and we see an area that can be improved upon, I think we take note and we work to make things better. And that's why I'm here at the legislature. And so that's why I'm presenting this bill.
Representative Ackland, anything else?
No, thank you.
Thank you. Representative Quam.
Thank you, Madam Chair. It seems to me as if it'd be a simple oral amendment to fix the neglect of covering this for Minnesota Care and MA. To me, if this is a very good program, why are we not making it universal? And so, I assume the author would love to have it fully cover. So you being the chair, can we address this now?
Representative Quam, no, we can't. And Representative Acomb has said that she's looking into what the cost would be, and it's her bill. And we do have a 24-hour rule. So no, we're not going to blow up her bill right now, or maybe it won't blow up her bill. I don't know, but it's really up to Representative Acomb to deal with the bill. And we're going to vote it out to, in its present form to state government finance. And if she is able to amend the bill, and, we'll bring it back if we're going to have costs that are carried in our committee. But I'm not at this time expecting that. So
Madam Chair,
Representative Quam.
Thank you, Madam Chair. For this session, there will be never any simple oral amendments accepted by the chair.
Well, Representative Quam, it's always the chair's discretion about whether an oral amendment is simple. This is not a simple amendment. It's a big change to her bill. So if there was a small issue, technical, something that needed fixing, probably that would be okay. In my judgment, that's not what this is. So we're not going to accept that oral amendment at this time. So, are there further questions from members before we vote on the bill? All right, I'm not seeing any. I just would comment myself that I think that this bill and the discussion, which I appreciate the discussion, and Representative Acomb, I think we accept your comments as they're offered. I don't think you need to, at least for my part, I don't view them as being brought in any kind of, negative spirit, but I think it does bring a good question. And for me, what this bill highlights is how dysfunctional our system of insurance really is. That, we're all, or some of us are discussing here today, if you find that you're ill and you need care, and suddenly, even though you're carrying insurance and probably in many cases paying a lot of money for that insurance, suddenly it's on you, it's out of your pocket. And that may, in fact, deter your care. And it may mean that you don't get care that you desperately need, that you don't get that follow-up because you can't afford to pay for it. That is a serious problem that Representative Acomb is really bringing before us. And, one small bill is not going to be able to fix that problem. She's trying to fix it in a sphere that she cares deeply about. And I think Representative Acomb quite rightly brings up the fact that, it's kind of luck of the draw, which disease you get and which thing affects you and your loved ones. And personally, I would argue that that's why our system is really a bad one, because if you need health care, you should get it, and you shouldn't be deterred, especially from life-saving, absolutely necessary health care or health care to keep you healthy, because you can't afford that out-of-pocket cost. Our system of out-of-pockets has gotten way, way out of whack. Frankly, I don't think it has any place in healthcare, and that's the system we've got. So thank you, Representative Acomb. Would you like the final word, and then we'll take the roll call on your bill?
Well, I thank you all for the discussion this afternoon, and I appreciate the opportunity to present my bill, and I would ask for your support.
All right. So we're going to take the roll on the bill, and Ms. Niederhofer, who's our steadfast roll taker here, is having power problems at her home. So let's see. Her bandwidth is very low. She's going to try to do the roll call. And if she finds herself unable to do that, I will actually continue that. It'll be a first for me, but we'll try to do it one way or another. Ms. Niederhofer, are you able to do it? My chair votes aye.
Liebling, aye. Vice Chair Hewitt.
Hewitt, aye.
Hewitt, aye. Lead Schumacher.
Schumacher, no.
Schumacher, no. Representative Acomb.
Acomb, no.
Acomb, no. Representative Backer.
No.
Incorporated, just one.
Backer, no. Representative Bonner.
Aye.
Bonner, aye. Representative Bierman.
Aye.
Bierman, aye. Representative Boldon.
Aye.
Boldon, aye. Representative Demuth.
Aye.
Demuth, aye. Representative Freiberg.
Aye.
Freiberg, aye. Representative Grunhagen.
No.
Grunhagen, no. Representative Keel, excused. Representative Morrison.
Morrison, aye.
Morrison, aye. Representative Munson.
Munson, no.
Munson, no. Representative Pryor.
Aye.
Pryor, aye. Representative Quam. Representative Quam.
Aye.
Quam, aye. Representative Reyer.
Aye.
Reyer, aye. Representative Schultz.
Aye.
Schultz, aye. Representative Wolgamott.
Wolgamott, aye.
Wolgamott, aye. Madam Chair, there are 13 ayes and 5 nays.
All right, there being 13 ayes and 5 nays, the motion prevails and the bill is on its way to state government finance. Thank you very much, Representative Acomb. All right, members, thank you for the good discussion this evening. Thank you for sticking around. We are ending a little bit earlier than we had thought, so that's kind of a blessing to us. Appreciate the good discussion this evening. So we will be meeting tomorrow at 3 o'clock and taking up a number of bills that I won't read to you, but they're on our agenda for tomorrow. So with that, have a great evening. We are adjourned.